Thank you all for joining us. For those of you on the line today, we are hosting our monthly Colorado Colorectal Screening Program webinar. We host these once a month from 12 to noon for mainly our patient navigators. However, today we have extended this webinar to our community partners, and we're really excited to see so many of you on the line and joining us. Because we have such a large attendance, we have gone ahead and muted everyone. So if you'd like to go ahead and introduce yourselves, you can do so through the chat. And also, as we go through our presentation, if you have any questions, please put those into the chat as well, and we will address them all at the end of the presentation. With us today, we have Dr. Patty Valverde from the Patient Navigator Training Collaborative. She is the director of the program, and Chris Jones, he is the program manager from the CBC Community Health. And without further ado, I'm going to go ahead and pass the baton over to Dr. Valverde and let her give an introduction.
Hi, good afternoon, everyone. Thank you so much for inviting Chris and I to speak. We will be talking about a survey that Chris conducted as part of his Masters of Public Health program, but I will initiate with some background to give us some context. So the Patient Navigator Training Collaborative has focused on training the group of staff that conduct navigation regardless of their title. So over the past 10 years, we have trained over 2,000 individuals who may be called patient navigators or community health workers, care coordinators, and every possible title in between. And we provide a range of courses to try to ensure a basic level of skills and knowledge for the navigational workforce across Colorado as well as across the United States. Many of you have already heard this spiel, but PNTC really came out of the seminal work on patient navigation. Denver Health, and specifically, was one of 10 sites around the country that was involved in the seminal clinical trial on patient navigation funded by the National Cancer Institute, and that was from 2005 to 2010. As part of the PNRP, or Patient Navigation Research Program, standardized training was an important part of how we can ensure that the patient navigators across all the sites are delivering navigation in a similar manner. We became aware that in Colorado, navigation was becoming more widely adopted and began providing training as an outgrowth of that PNRP program back in 2008. Now, you can imagine back in the mid-2000s, most of the navigators were working on cancer detection, abnormal screening, and treatment, and our courses back then were focused on that workforce. But over the past 10 years, we have seen patient navigation become widely diffused throughout the healthcare system and out in the community. And our courses now have tried to reflect the changing workforce, where navigators are delivering navigational support, the type of navigational support, and so our types of courses have changed dramatically over the past 10 years. Our initial program was funded from the state tobacco tax, and but there have been times where we have gone to a fee-for-service basis. We've enjoyed almost 6 years of state tobacco tax funding through this Colorado Cancer and Pulmonary Disease and Cardiovascular Disease, or it's called CCPD funding, and are now about to move into a fee-for-service structure again this summer. So we really are a collaboration, and this slide shows all the different agencies and individuals that have been involved in PNTC over the years, from Denver Health at their Denver Prevention Training Center to Red Rocks Community College, various AHEC centers, and our wide range of trainers that work within navigation, manage navigators, and work across the state of Colorado. So early on, we developed a set of core competencies, and this was reflected reflected the original thoughts around the skills and knowledge that navigators should have back in the mid-2000s through the PNRP program. And it has gone through a number of iterations over the years, but you'll see that it's similar to the Colorado State's competency list and very similar to the variety of competencies for navigators or people who conduct navigation throughout the country. And it includes professional boundaries, ethics, communication, identification, and removal of barriers, among other competencies. Now, to train on these competencies, we've developed a number of levels of courses, starting with what we call level 1 or foundational course, where the target group are the non-clinical or non-licensed individuals who conduct some type of navigational support for patients through a healthcare encounter or throughout a healthcare system. And again, we don't care what the title of the person is, but our target group or our focus is to serve those who are unlicensed and are conducting navigation. So we also have what we call advanced courses, where we're able to dive into particular competencies or components of navigation. And those include, for the navigators working on some kind of health behavior change, the use of motivational interviewing can be particularly helpful, care coordination, health behavior change, and understanding the emotional and social impact that disease or chronic conditions have. In addition, we have developed courses for the people who manage or supervise and evaluate these patient navigator programs. So now I'm going to pass it on to Chris, who's going to discuss his specific project that was his capstone project, and he'll give you a little bit of background and then dive into the method and the results.
Thank you very much for the intro there. There is a lot of background with this stuff, and so I do appreciate the help there. And thank you for everyone joining. This has been an awesome project to be involved with, and I'm excited to share some of the findings. Just as a preface, this was a huge survey, so as Patty mentioned, this was kind of specific to the project that I did. But there are a number of other things that I'm sure will be analyzed further, because there are just so many angles biostats and public health nerds can get into. So just a brief intro. As we're all acutely aware, healthcare costs in the U.S. are just kind of out of control. I mean, as a point of reference, in 2015, we spent $9,451 per capita on healthcare, with the next closest country coming in at $6,935, which is a pretty big gap. And we all know that we spend that money for worse health outcomes. So how do patient navigators fit in? Well, they represent efficiency or potential cost-effective workforce that are capable of increasing efficiency in the healthcare system, as well as addressing health disparities by breaking down barriers such as client mistrust and language. So the project purpose, the purpose of this particular project was to assess patient navigators' perceived confidence in utilization of the PNTC course competencies in their job roles. It is kind of a mouthful. I will be using course competencies quite a lot, as well as confidence in utilization. So methods. So initially this started last summer. Time sure does fly thinking back. We did a literature review to set up just the basis of the survey content itself, and then spent the summer just designing it, getting feedback from PNs, working with Jody Driscoll and Patty and Aaron to just really make a well-rounded, robust survey that actually ended up taking all the way through till about the end of the summer and beginning of fall semester. And so we really did think it was a strong survey. The survey content revolved primarily around the core PN competencies that Patty introduced, in terms of their confidence in using those and the daily use, or how frequent they're being used on a daily basis. Professional development aspirations, and organization utilizations of PNs. How are they being used? Are they being used adequately? So on and so forth. And simply career satisfaction. Statistical analysis was conducted on the results via SPSS, with, again, an emphasis placed upon assessing the competency, utilization, and confidence.
Can I just mention that when we refer to competency, so competency is basically like a rolled up domain of knowledge and skills.
Yes.
So, so that's what we're using in terms of competency as a definition.
Thank you. So just a brief overview of some of the basics. A total of 516 of the 1,014 invitations opened the email, and 318 individuals did respond to the survey. 318 also responded to completing the demographics, and then 129 completed the core competencies. And these number breakdowns are pretty much were built around the idea that we're focusing on folks who are actively conducting PN work. Whatever the title may be, but the survey would pretty much cut those who said, I'm no longer employed as a PN or doing these sorts of jobs, and send them to the end. So that's why there's a reduction in the numbers there. And this a little bit more. So again, the 15 core competencies were assessed for daily use and confidence. Means of competency and confidence in daily use were conducted, and then linear regression analysis for a composite competency variable was conducted to identify influencing factors. So just to kick it off, we'll kind of go through some of the demographics of this workforce, which I always think helps paint a picture of this group. So, surprisingly, I guess, or potentially surprising, I find it very interesting that the PN age is almost perfectly broken down by age brackets. We have 32% in the 18 to 34 category, 32% in the 35 to 49, and then 29% coming in at 50 to 64, which is 5% over 65. Race and ethnicity is pretty well represented, with white Caucasians coming in at 54%, African American or Black 8.18%, Native Americans or American Indians 0.63%, Asian Pacific Islander 4.7%, and then Hispanic Latino 28.6%, with the remaining identifying as other 4.4%. PN gender, predominantly female workforce. 87% of our respondents were female, 12% coming in as male. And a bit of a background on the graphic to the right, the system I used for these graphics were a little bit limiting on the display labels. So the labels on the actual pie chart itself are just the N, and the percentages are shown on the key to the right. So this is the organization type. So what kinds of organizations do these folks work for? And I like seeing these because I think it really paints a picture of just how diverse the skill set and the settings that these folks all work in. So we have cancer centers, community clinics, nonprofits, which cover a wide range of groups, health plans and insurers, hospitals, health departments, and then private practices. Right. And again, on this graphic to the left, these are the N, and I just love seeing this as well. These are the health conditions that folks reported that they work on. And we again see just a really wide range of pretty much health conditions that these folks work with. So breast cancer, cervical cancer, colorectal, all cancers, mental health, diabetes, CVD, chronic diseases in general, asthma and COPD, and then general navigation, which came in as the most reported, was the last there at 97. And then PN preparation after level 1. So this was just simply reflects well on the PNTC. It was how well prepared do you feel for your job after taking level 1? And no one said unprepared, which is always a great thing to see. Most came in with most came in with very well or well prepared at 50%, very well prepared at 32%, and then somewhat prepared at 18.46%. And then PN salary. So just a brief gauge on the PN pay range. You see most folks are sitting in the $30,000 to $40,000 range, which wasn't a part of my primary analysis, but was definitely something folks mentioned as a barrier to continuing longevity, continuing as a PN. But yeah, you see just kind of an even dispersion around 20 to 50,000 is the bell curve there. And then a little bit more of some of the thematic stuff. So what changes, if any, have you made in your practice as a result of training or taking PNTC trainings? We have change in current best practice and guidelines in my own work. 40.5% said they did that. Change in my professional practice, 34.18%. And changes in policy procedures, so simple things, at 15%. And then I didn't make any changes at 27%. So again, though, this does reflect well on the PNTC trainings. The broad proportion of folks did leave with something that they felt valuable and that they wanted to implement in their own work. And again, before we get into the real nitty-gritty statistics, I think the thematic stuff adds context. So these are just a few quotations from some of that. So please give us examples of how you made changes in your practice as a result of taking PNTC trainings. So asking open-ended questions, trying to find the motivation for each patient to move them to change, and breaking barriers of care, lack of understanding, transportation, money, and limited resources. I ask about social determinants of health, as well as medical issues, and speaking with clients. And this is something we saw a lot of folks really coming to understand that social determinants are something that can't be stripped away from the work they do. They're integral to any of these conversations. And then, I'm keeping better boundaries. I remind myself what slippery slopes can lead to, and I feel supported. I don't feel like I'm the only one in a navigator position, and I know I can always reach out to the PNTC for help. Additionally, I'm always impressed by how PNTC continues to be on the cutting edge of patient navigation. And that's something I think really reflected well in the PNTC, because I know in my own work, I do see folks who are in these rural settings or just smaller settings, and they're the only one in the organization doing that work. And I can imagine that feels very, very singled out, very low. So it's good to hear. And then lastly, on thematic, so top 3 skills. So we asked, please provide us with 3 examples of the most important skills you learned from PNTC courses that have been useful most in your job roles. So overwhelmingly, we saw MI, motivational interviewing, and general communication skills. So open-ended questions, really those skill sets that wrap into action plans and goal setting, which is, but not surprisingly, the next most cited skill set was goal setting, action plan development, assessing readiness to change, and addressing barriers, which is all wrapped into the core skill sets that a PN needs. And then third, we come in identifying community resources, referrals, and PN tools, which I know is a difficult thing to do, especially for some of these places that just simply have a lower amount of resources. And then lastly, cultural awareness, social determinants of health, disparities, and LGBTQ community needs were cited pretty commonly. So it was really cool to see things that we think we know PNs want and need and use, and actually to have them reflected in what they say they're doing. So now into a little bit more of the numbers. Here we have a table, and it'll actually be cut between this slide and the next. These are the competencies themselves that the PNTC has in their curriculum, and their descending order for these are just mean frequencies. So average amount of competency confidence on a scale of 1 to 4. How confident are you in using any of these competencies in your daily use? So they're descending from highest confidence to lowest, or highest average. And then on the right side of the table there, we see the utilization or frequency. So how often are you using said competency in your daily role? And again, they're descending from highest to lowest average. And this kind of just gave us a little bit of an interesting look at what's highlighted here are things that were relatively high on confidence, or vice versa, relatively high on utilization, but noticeably lower on confidence. So there are items that, the PNTC wanted to know about, where so folks are saying they're using the skill set or the competency of helping clients identify barriers and problem solve solutions, but they're a little bit less confident. And so there's only happened with, as we'll see in the next slide, another set of competencies. But what really to get out of this is, interesting enough, most things correlated pretty well with how confident they are and how frequent they're using the item. And also a great reflection on the PNTC is that on these scales, so on the left, we have a scale of 1 to 4. On the frequency, just basics of survey responses, we did a 1 to 3. And you'll notice that most of these, if you pull them out, are really high relatively. No one really had a 0 or a 1 or anything like that. So we have competencies that we are seeing folks who are confident in using them, but more importantly, that they are actually using frequently. So there are things that are relevant. So you may be confident in some skill, but if it isn't relevant to your job, then it really isn't a point to have PNTC teaching you how to do it. So that was a great reflection to see. The second half of that table is just the rest of these competencies. And so we see one more skill set, you know, and this is just something that I'm sure the PNTC just taking note of, you know, to refine their future coursework, was just a little bit lower on the developing a collaborative action plan while they're also using it more frequently. Lastly, which I personally think was a reflection of just the ridiculousness of our healthcare system to some degree, is the lowest ranked competency, both in terms of confidence and utilization, was the assisting clients with information pertaining to health insurance and or payment options, which may be a reflection really of the political climate, changes that happen every day. You know, I mean, you watch the news and it can spin my head around on what I think is actually happening with our healthcare system. So just another area, you know, that the PNTC has taken note of and was advised on through our work on this. So again, just to wrap up that piece, so the average confidence across all 15 competencies came in at 3.17 on a scale of 1 to 4. So again, very, very high confidence rates that were reported. And then average daily use on a scale of 1 to 3 came in at 2.59. So again, we see these 15 core competencies that have been chosen pretty well, obviously, because not only are they teaching them well, but folks are using them very frequently. So regression analysis, you know, this is one of those items where I'm sure anyone watching has their own ideas, and there's so many different angles we could have approached from. I just scratched the surface on really the options of analysis here. But from my own work and talks with Patty and Jody, I really wanted to see, has supervisor support played a role in your effectiveness or your confidence in taking or conducting these competencies on your daily role? So we asked a handful of questions about, you know, does your supervisor support you in your daily options? Do they give you options or provide opportunities for professional development and ongoing support, things like that? We balled them into one composite variable. Along with the 15 competencies, we created a composite variable for those in terms of the confidence. And then conducted the linear regression to analyze if supervisor support has any influence on PN's confidence in their job role. Or perhaps maybe how many, if folks have taken more than one PN course, are they going to be more confident in these competencies? So those were the two primary meats of this regression analysis. And so linear regression results, so, you know, what I kind of expected and what we found was supervisor support was found to be statistically significant factor on the confidence of PNs to execute the 15 core competencies in their job roles. While interestingly enough, taking multiple PNTC courses wasn't found to be significant. And so, you know, that maybe could honestly be a situation. There's a bunch of explanations that could be done, and I think that will be further analyzed. But the supervisor support was interesting, and I'm very happy to see that, because I do think that is a primary component to any PN doing well in their role and staying in their role and enjoying it. So a bit of discussion. So this is good news for the PNTC. So overall, we saw some really wonderful results. You know, folks reported high confidence overall in conducting competencies in their role. They not only had high confidence, but they're actually using them frequently. So they're relevant to their jobs. Supervisors. So supervisor support is a content area that the PNTC, well, they already have courses, will continue to focus on and probably build on a little bit. But in general, for the PN workforce, that's something that I think we should all be aware of, is while we train these folks and cut them loose on doing a lot of this work that's in between a busy clinic or whatever, you know, any environment we work in, we're all pulled in a million directions. We can't forget that these people are better off and do better in their job when we're working with them and focusing and continuing to build and you know, build off one another. There were, you know, limitations around surveys are always going to be there. We had pretty strong audience response, but there's always going to be selection bias and response bias. One fortunate thing for this particular survey was it was administered to folks who had taken the courses, you know, a time length longer than just a couple days. This isn't a survey that was given to folks right after they completed a course where they might be really confident in things. So sometimes some of these folks hadn't taken a course for the PNTC in a year or two. So we think that really does help some of these results. And just a bit more information can be found on the Patient Navigator Training's website, and do check them out on Twitter and Facebook. Acknowledgements here. I wouldn't be here without my PNTC friends. I probably wouldn't have an MPH yet either. So Patty, Jody Driscoll, Aaron, actually should be on here too. Thank you for your support. My advisor Yvonne, and capstone teacher Virginia, and then patient navigators of Colorado. You all make this possible, and we love working with you, and the work you do is important. And then my own job role at CPC Community Health. And questions that I will do my best to answer.
So I know that someone, thank you, Chris. I know that someone was asking about pay range. For that question, we did ask them how many hours a week they work. It was an open text type of question. So that will be our next analysis, just to make sure that we were getting a pay range for full-time. But when I've gone through the open text responses, they were generally full-time people. So I don't think it will change much. And also those are the pay range that Chris found in the survey is consistent with the pay ranges that we're seeing in job descriptions. So with further analysis, I don't expect it to change. Kristen, or did you have anything that you wanted to say? Or
yes, I do have a couple comments. So we will be, I do believe these slides will be available on the PNTC website, and if it's okay with everyone, we can upload them onto our website as well, or the recording of this presentation, in fact. I was wondering if you could speak a little bit about ways that patient navigators could help increase that supervisor support that you all were talking about, because I think ultimately having that type of support is important in a number of ways, and especially when you think about sustaining that role of patient navigation within the clinics. Really having a clinic champion for the cause is very important for this role. So any thoughts on that you guys might want to share?
Yeah. Well, I guess I would, from my perspective and work with community health workers on a CHHS program, I think one of the biggest things, communication goes both ways. But I think, like you had mentioned, a clinic champion is really based around someone who understands the role. So one of the questions actually we'd have to maybe look at again was how well an organization is utilizing them. And I think that question really pokes at, do they understand who you are and what you do? Because we find a lot of turnover in the sites that we work with. Doctors come and go. Doctors pay, their medical bills or their school bills, and then they head back to the city. And so you build a relationship. Maybe it's great for a year, and then it's gone. And so, I think having a core structure in an organization, just in terms of disseminating what this person does, what the PN role is capable of, because I think sometimes they're shortlisted on this is kind of an administration position. And it's like, no, the skill set of a PN is very useful and very broad.
Yeah, and we hear that a lot in our courses where navigators say that their supervisor or manager doesn't really understand what they do. So to respond to that, we have conducted supervisor trainings. We're now moving it online so that it's a tutorial that supervisors, managers, planners can take. And then I was hoping Erin might be able to talk about a new effort that we're undertaking with the State Health Department to try to improve the supervisor's understanding of PN role.
Sure. So we historically have offered a one-day in-person course geared towards managers and supervisors, as well as those who are thinking of starting a patient navigation program. And what we've heard is hard for people to sometimes get away from the clinic for a full day. And so we've converted this into a webinar series, and it will be launching the end of March. And we'll have webinars March, April, and May all this info will go on our website by the end of this week. I'm still finalizing some of the descriptions for the webinars, but they'll be over the lunch hour, an hour long, and we'll cover topics such as writing a patient navigation job description. What does that look like? What do I need to have in there? What kind of people qualifications am I looking for when I'm hiring these positions? Other topics are role clarity and how you think about different members of the healthcare team. So yeah, more details on this series will be available really soon, and we're excited to launch that this spring.
I just want to mention the third topic is team-based care. So how do you actually integrate the navigator role into an already existing team? What are some of the evidence-based methods that we know about that have been successful?
Wonderful. And we will, the Colorado Colorectal Screening Program will be sure to share all of those links and webinar information with our patient navigators as well, because I'm sure that these topics will be of huge interest to everyone on the line and maybe even your supervisors, clinic team members, and so forth. So really looking forward to that. Let's see, we just received a new comment. I find that there is a lot of reinventing the wheel going on in healthcare, and I see it happening in navigation training. Do any of you have any ideas of how to stop wasting resources on reinvention? That's a fantastic question. I am going to let Patty address that one.
Sure. So I think that in all of our courses, we try to emphasize what we know in terms of knowledge base for providing care to patients. We just did a lit review of navigator interventions and CHW interventions that are what we would call navigation. And there are, I think it was something like 600 abstracts and articles. So you're right, there's a lot of information out there. So the difficulty is knowing where to look, whether it's in research or the community, various websites where you can find toolkits, you can find models, you can find information, training information. And then trying to find a way to deliver, synthesize and then disseminate what we already know. So certainly in the supervisor course, we're always, we have a whole section on where do you go for evidence-based, promising practices, but what's already been tried, and then learn from that and figure out if it would fit in your own setting, because we certainly don't want to reinvent the wheel or the amount of effort it takes to create something without looking and seeing what's already out there, what has worked and what hasn't, is immense, and no one has that kind of time. So if you have any suggestions on specific type of information, tools, resources, that you think would be helpful and you're not finding it, let us know, and we would be happy to work with CCSP and the Alliance and other entities to get it out so that people aren't struggling. And that's also one of the, I think, benefits of attending a course. So for example, the supervisor course, even though supervisors had difficulty carving out a day or 2 days to attend, there was so much resource sharing going on and networking, which assessment tool was being used in one setting and it may be applicable to another, or maybe it just takes some modifications, and which outcome surveys or outcome measures they were using. And so we want to make sure those opportunities are still available because, they're very helpful. Erin, do you want to add anything to that?
I don't think so.
Okay. I did want to mention, we have a comment from Jody that says that the PNTC is available for consulting on models that work. So any further comments, or if you'd like to discuss this further, I think they're more than willing to get those conversations started. And excellent. Okay, Hillary asked for the PNTC website, so we've got that in the chat. Are there any other questions for, oh, let's see.
So there was a comment about the gender makeup of the navigator role. Denver Health does have, well, Denver Health actually had one of the earliest navigator programs in the state, along with, you know, Linda B. Certainly, boy, she was like a decade before everyone else. But at Denver Health, there was a men's health initiative that really was a navigator and community-based model, and they're still around. And what was really interesting about that program is that they were one of the first programs to show how they could move from a grant funding foundation to operational funds, because they were so successful in working with their patient population, making sure that they were using insurance, getting onto insurance, and then also utilizing healthcare services appropriately. And so, yeah, I mean, they've always been a wonderful model to look at.
That unicorn of embedded funding.
And I do want to encourage everyone on the line, those of you who are patient navigators, community health workers, and so on, if you have not yet taken any of the Patient Navigator Training Collaborative's trainings, we highly encourage you to do so. I know for those who have already completed level 1 that there is a health equity, a level 2 health equity training coming up in June, in addition to a few more of the online ones which Erin mentioned. Do you want to talk briefly about the Navigator Wellness Hour?
Sure. So that is something we developed in response to feedback actually from a navigator who was feeling kind of isolated in his role, felt that people needed a place to come together and support each other and really focus on health and wellness, and just a chance to reconnect. So we developed this Navigator Wellness Hour series, the third Wednesday of the month, 11:30 to 12:30 by Zoom, and that's free to Colorado navigators. And we have Dr. Rebecca Ritchie, who's a really great facilitator, shares her expertise. We've had a session on self-care. We've also had a session on preventing burnout. And then our upcoming session will be how to help families with, or help clients with family and conflicts. So different strategies around that. So it's really fun and interactive because we do a short PowerPoint presentation, and then we do a small group activity where we actually, if you guys haven't experienced the wonders of breakout rooms in Zoom, you get sent into like a virtual room and you can actually talk and connect with your colleagues. So look for that on our website. And someone also asked about the supervisor series. That is also free to Colorado navigators, and it'll be a small cost to those out of state, but they're welcome to participate too.
It looks like we have 2 more comments. Let's see. All right.
Oh, Michael is on there.
I see we have a question from Catherine. How do you measure success? How do you know if navigators are making an impact on changing a patient's behavior? That's a fantastic question.
Do you want me to?
Well, I mean, so from my perspective, my personal perspective, right, I think that's all relative to the program or to the condition or what are they working on. You know, for a lot of these programs, there are hard outcomes, whether they be through just lipid panels, BMI, things like that. If it's CVD related, that's my wheelhouse a little bit. So, you know, from my perspective, the work I've done, these folks use these tools, their training tools, and apply them in, for instance, diabetes prevention and CVD prevention. And then we actually are able to watch the hard outcomes of reduction in global risk score, reduction in LDL, things like that, or improvements on vice versa. But
yeah, so I would say we do we have offered an evaluation course, and it's actually 2 days, and you get walked through developing a logic model. And so you'll see that there are a lot of different types of outcomes. There's long-term outcomes, which is the, decrease in risk for some kind of disease. There are also more intermediate and closer outcomes. So, within your program, you might look at all of those different types of outcomes, and one might be just movement of the person towards making change. So I've heard of some programs that look at the readiness for change, and if they move, from pre-contemplative to contemplative, that's considered success. And over time, they might actually get in preparation and eventually in action. So I think it's all depending on how the grant or the proposal is written up, and if your your manager, or if you're involved in that, and you want a little more skill building, the evaluation course is great in terms of developing a logic model. And then from there, you figure out the metrics, and you figure out how you're going to collect the data and all of that.
And I can speak a little bit towards how the CCSP patient navigators measure success. We look at health outcomes regarding colorectal cancer screening. So decreased number of no-shows for patients who have received patient navigation services. That's an evidence-based method of measuring how well patient navigation works. In addition to that, improved bowel preps. We've seen that in the past, providers will be hesitant to take patients from, let's say, a clinic who's notorious for having poor bowel prep results among their patient population. When patient navigation programs are implemented, you can see an increase in the bowel prep rate, which then leads to a better partnership with your GI providers, which leads to an increase in available appointments for colonoscopies, and just increased partnerships. So those specific outcomes, we find that in our data, and you can also find that research in the literature as well. So again,
Go ahead.
I think I was just going to say a closeout sentence, so go for it.
So that's a good example of a hard outcome. But when you are dealing with, so the low-hanging fruit, the people who are we're leaning towards getting a colonoscopy but just hadn't done it yet, but really aren't, and they're not really ambivalent. Those are the outcomes that you would want to measure. Now, certainly for people, the more difficult clientele that are pre-contemplative or really ambivalent, so they have many reasons not to get the colonoscopy, or won't even consider getting the colonoscopy. We acknowledge that getting, that metric of bowel prep and show rate and getting the colonoscopy, that's way further down the line, because you have people who are not even ready to get it done. So that's when it might take multiple contacts, multiple touches for them to move in that kind of readiness stage. And that's where some people really do look at those very intermediate or very early kind of, not metrics, but indicators that you are succeeding, that you are helping to move someone along. Because if you schedule their colonoscopy and they're not ready at all, they're very ambivalent, then you're not going to change the no-show rate or the bowel prep rate, because they're not going to show up. So there's a lot of early work, and then potential measuring of so you get credit for all that early work that gets to the person being ready to do the colonoscopy. And for me, when we're talking about behavior change, there's those hard metrics, but we know that there's all that work that goes into helping someone being willing to make the change and then actually following through with it, when you have that big ambivalent group that's like, I don't really want to do that. And, it's, those are a lot harder to work on. So that's why I was saying the readiness might be something that, you know, just helps you to show that those skills are in place to help, because you're not convincing someone, you're just trying to support their interest and their own motivation to get them to do it. So, so yeah, there's, I think, some other maybe internal metrics that you may want to look at.
And while it's less, I don't know, well, it's more difficult to prove, I suppose. I just wanted to mention too, one last metric I'd say is just economic efficiency. So like the Denver Health example, they wouldn't have wrapped the Denver Health patient navigators into their own financing system and funded them internally if it didn't make sense.
Right.
And while there are fewer examples, and I think that's in large part because of the difficulty in getting people to really understand this workforce and utilize it well, it's been proven that they do lower costs and increase efficiency. So I think that's just another ball of the whole PN workforce.
I'm glad you brought that up. Yeah, that's very important to kind of
it's hard to get insurers to like,
but yes. We've got, let's see, 2 more questions so far. Where do the trainings take place? Erin, do you want to go ahead and answer that?
Yeah, sure. So a lot of them take place in Denver Metro, but we also offer them around the state. Please take a look at our website. Our spring calendar is up. We're having level 1 in Colorado Springs, Alamosa, and Delta. So those, so we really are wanting to expand or cover the state. And as Patty had mentioned earlier, we're moving to a fee-for-service model after June 30th. So please take advantage of these trainings while they're offered at a nominal cost, because we only have grant funding through the end of June.
And how would you address creating open conversations that are needed between hospitals, clinics, and organizations to be able to create a healthier community by sharing resources?
Yeah, so I think that's certainly one of the, my understanding is it's one of the goals of the new RAISE, where they're really looking at community-based services and social determinants of health, as well as the, what are they called? Community health connectors?
That's what I was thinking.
Regional health connectors. So I think there, you know, over the past few years, there's a growing impetus or interest and eventually infrastructure so that all these different groups within a community will actually be working together and communicating. In the past, and certainly in the cancer field, there are a variety of examples through coalitions where people would come together and sorry, I just got distracted by Jody's note. But, you know, through coalitions and trying to work collectively on issues around access to care, we've seen that happen. But as Jody said, with the RAISE, we're, you know, we'll see the impact of health neighborhoods. I think it's an exciting experiment.
And RAISE are the organizations formerly known as RICOs, right? Mm-hmm. I have to remind myself of that every day. RICOs are now RAISE, in case anyone has gotten confused by any messaging out there.
Would someone like to explain the regional health connectors?
Sure. As far as I, and anyone in the chat, please chime in if you have more comprehensive details.
You are a regional health connector.
Yes, but I understand they don't provide any direct patient care. They're more of an organizational support liaison to form these connections in the community. For instance, if they talk to family practice, for instance, who's like, a lot of our patients are experiencing a barrier to physical activity. They wish it was more affordable. Well, the regional connector might go in and form a partnership with the local community center and be like, how can we offer discounts to your patients? And how can I facilitate these conversations and these access to resources?
Thank you.
Yeah, I would just echo Patty that it's getting hard to ignore this workforce. And one of the core things, right, is from top down understanding, again, their role. And their role is being that nexus to some degree of these community resources. And so we notice that's such a big problem where a lot of these counties that we serve or work in are very sparse on resources, but there are ones there. And when you connect them together, at least there's some net you can create in terms of support. So I think it's growing. But yeah, it's definitely something that's just ongoing, you know, definitely.
Well, we've got about 10 minutes left. Are there any final questions, comments, thoughts, plugs that anyone would like to share? This has been a fantastic conversation, by the way. Thank you all for your engagement, and we really appreciate it.
Yeah, definitely.
Yeah, so we appreciate everyone who completed the survey.
Yes.
We think we will send out a second wave just to get some more responses to make sure we didn't miss, particular groups. But I think that it is, it's good for us, both as a training center, also for the state to assess how well the competencies that we think you all need to know are actually reflected in your work. That's always our biggest fear, that we're training for things that you're not actually doing. So we really appreciate your feedback, and this is also something that the state and nationally we're trying to really solidify and standardize in terms of competencies for navigators. Let's see.
The Vita Sana program, an OHE-funded program, and Out of UC Health North, has been working with CHW since 2012 and have partnerships with our local community centers to offer free PA programming.
Physical activity.
Thank you. We are happy to chat with others interested in what we are doing with the community. That's fantastic. Thank you so much for sharing that, Edgar.
Yeah,
we would love to hear more about that. If you would like to send us your email privately, perhaps we could have an offline conversation about that.
John also asked what outreach is underway to educate the medical and Colorado community at large that we exist. So I think CCSP does considerable outreach and presentations around the state and nationally. Our training program, we try to also educate the public on navigation and the role and the workforce. And then certainly the state health department has their own workforce, what is it called?
Workforce Development Initiative.
Workforce Development Initiative for health navigators. And so at the state health department, they also conduct a number of presentations and are working with employers to really understand what this workforce can do. If you have other ideas and suggestions, please let us know. And I think all of us would be interested in helping to educate the public on and stakeholders on the role of the navigator and all the wonderful work that you all do.
Well, it looks like we might be able to give you back 8 minutes of your day. I'm just going to do a quick housekeeping CCSP plug for our navigators still on the line. Please remember that your February data is due March 10th. Likewise with billing, that's due March 10th as well. And there was one more. Please remember to distribute your patient satisfaction surveys. If you have any questions about that, please contact myself or Shannon Prey. And you most definitely have my email address. I think I sent at least 3 emails out today, so thank you for bearing with me. So yeah, any questions, comments, feedback that you all think of after this webinar has closed, please send them my way. I'm happy to connect you with the folks in the room today if there's any other information you might like to receive.
All right.
Thank you
everyone.
so much, everyone. Enjoy the rest of your day.